Hello, my friend. Welcome to my show Chronicles of Alana RN, and thank you for listening. My name's Ritika, and I'm excited to finally alter my introduction after 12 long months, and everything I've been working towards with this podcast is a testament to the new title I get to hold. So, I am now a critical care registered nurse specialised in emergency working out of Melbourne, bringing my experiences and learnings to a wider audience. Thank you very much. It's been a long time coming. So today, we'll be talking about heart failure. As per usual, my disclaimer, I will not be providing any personalised information. All names, numbers and results will be altered to protect the privacy of the patient this story is derived from. So let's get started. Heart failure. It's one of the most common chronic illnesses in the world, but it's also one of the worst chronic illnesses to have. Let's discuss why. Heart failure, or otherwise known as CCF, congestive cardiac failure, is a condition where the heart begins to pump inefficiently. This leads to reduced blood return to the heart, and this manifests as two major symptoms: swelling of the feet and shortness of breath on exertion. But why? Heart failure used to have, some people still use these terms, but used to have two terms, and I'll discuss them briefly, but I want it known that these terms are no longer widely used. They only serve a purpose in this episode as a way to visualize which side of the heart affects which system. So these terms are actually left and right-sided heart failure. Left-sided heart failure affects the lungs, because if you think about it, the left ventricle is the ventricle supplying the whole body. But if the left ventricle can't pump effectively, then this backs up into the left atrium and then back into the lungs, causing extra fluid to hang around. This reduces the efficiency of gas exchange and then produces shortness of breath on exertion. Right-sided heart failure affects the peripheries because it's now the right ventricle that can't pump effectively. This then backs up into the right atrium and then into the superior inferior vena cava and then back into the body. This results in leg swelling, primarily due to gravity. And this is where all the extra fluid pulls to. But say someone that's bedbound, this fluid may even pull around the buttocks or like the lower back. So now we know that heart failure has the potential to affect two very different parts of the body. But heart failure is actually no longer classified like this. Instead, it's classified heart failure with preserved or reduced ejection fraction. Ritika, you ask me, what on earth is an ejection fraction? Basically, on basic of basics levels, ejection fraction is the ratio of how much blood leaves the ventricles after entering the ventricles. So say 100 mils, every time the ventricle relaxes, 100 mils pours in. But when it contracts, only 50 mils comes out. So your ejection fraction, so your fraction is 50 mils has left, 100 mils came in. Meaning your ejection fraction is 50% because 50% of the blood has left. The more blood being left behind, obviously due to that fraction, the lower your ejection fraction. So say if only 20 mils comes out, so 100 mils comes in, 20 mils comes out, your ejection fraction would be 20%. And that's quite poor. I think off the top of my head, ejection fractions of, I think, above 60% is like preserved, or like within 40 to 60. I'd have to look that up. But there's between 40 to 60%, I think, is preserved. And then I think anything below that is reduced. But don't quote me on that. I could be wrong. Basically, what happens is because of this leftover blood, less blood can enter, causing more blood to be left behind and causing that chain reaction I mentioned just before with the lungs or the legs. So that's pretty much CCF in a nutshell. As the disease progresses, symptoms worsen. There is no cure to CCF, and like other chronic conditions like COPD, it can result in death when progressed to end stage. For an in-depth review of what passing away from CCF is really like, you should check out my previous episode I think it's called My First Experience with Death, or Up Close and Personal with Death is what it's called. One of my earlier episodes. Anyway, while there is no cure, there are treatments to slow the progression. While these treatments do not overtly increase cardiac function, they reduce the side effects of the extra fluid in the lungs and legs, making quality of life better. The primary medication used to achieve this is a very well-known one, furosemide, also known as Lasix. Now, this drug is a loop diuretic, which increases the amount of fluid being excreted, and to the masses, it's often known as the fluid tablet because it's well known for its side effect of increased urinary frequency. So how this loop diuretic works, it's called a loop diuretic because it works on the loop of Henle in the kidney. So that's why it's called a loop diuretic. But it works by reducing the concentration of electrolytes that are reabsorbed in the filtration process. This significantly increases the amount of sodium, potassium, magnesium, and calcium, but most importantly sodium, that is being excreted through the urine. Due to the powers that be regarding osmotic pressure, when sodium is excreted, water comes with. Hence a reduction in extracellular fluid, which is that swelling where the swelling is sort of taking place. And this decrease in extracellular fluids leads to reduced swelling, reduced shortness of breath, but also reduced cardiac output and reduced BP, because you're just physically reducing the amount of volume you've got in your body. There are other diuretics that spare electrolytes if low sodium and low potassium become ongoing issues though. So we can work around these, and sometimes people get electrolyte replacements. So they get put on electrolyte replacements to sort of balance out what the diuretics are doing. So now we get into what I really want to talk about this episode, APO, acute pulmonary edema. APO is a respiratory emergency. In essence, the heart is failing to pump so much that the fluid should be moving from the lungs back to the heart is stifled. This leaves fluid in the alveoli, impairing gas exchange, inducing severe shortness of breath, hypoxia, and death if not treated imminently. If you think about my very crude, quick explanation of the pathophys of APO, it sounds similar to conditions like pneumonia, where exudate sits in the alveoli due to infection and the inflammatory processes. So what's the difference and how can we tell? Often, but not always the case, pneumonias are found in the bases of the lungs, but are almost always concentrated to a specific region. They also sound like coarse crackles, sort of like that icky wet cough people have when there's phlegm involved. However, to discern edema, a common finding on auscultation is what we call fine creps, creps being another word for crackles. The best way to describe this sound is if you rubbed a few strands of hair between your fingers into either a stethoscope or a microphone and listen to sort of the enhanced recording. At least, what I mean by enhanced is if you do it up to a stethoscope, you're hearing it louder. If you do it into a microphone, you're hearing just that very subtle sound. At least that's how I was taught to imagine and interpret the sound. In APO, these fine creps are often found in bilateral midzones, but in extreme and severe cases of APO, they can spread to cover the entire lung field. This is what's called full field APO. Now, the reason they originate in the midzones is that the pulmonary arteries and veins enter the lungs in the middle, not from the top. If you're having trouble sort of picturing this, I suggest searching up a picture of the lungs and finding out where the pulmonary vessels sit. So now that we know why and how APO occurs, how do we treat it? Well, in fact, we will be taking a trip down episode memory lane back to our known concepts of NIV. On top of the aggressive diuresis, so increased diuretic therapy, most often IV, we often put the patient on BiPAP. And sometimes they may even come in on BiPAP if AV starts treatment earlier. So coming back to pathophys, if we think about our VQ mismatch, which I have spoken about previously in my PE episode, fluid in the alveoli is a ventilation issue, as gas can't exchange through fluid. This results in a shunt, meaning blood is flowing through the capillaries of the affected areas, but there is no gas exchange happening. as opposed to dead space ventilation, where gas is there to exchange, like we would see in a PE situation. Gas is there, but there's no blood for the oxygen to latch onto, or CO2 to do the opposite, due to lack of blood flow. So in APO, you are left with a shunt. I don't think that would be very pertinent in like a sort of emergency situation to know, but it's good to keep in the back of your mind. Therefore, the component of NIV that is actually treating the APO is the CPAP portion. But why? The mainstay of CPAP, or continuous positive airway pressure, is keeping the alveoli expanded more than they usually are to increase surface area, improve gas exchange, and aid in the displacement of fluid back into the bloodstream. But there isn't really much reason to put someone just on CPAP in ED, so we often do BiPAP. In 10 out of 10 cases, someone with APO is severely short of breath, will likely have moderate to severe work of breathing. So while CPAP treats the disease process, BiPAP will aid in work of breathing and make it easier for patients to breathe, reducing distress and easing fatigue. One other therapy that we do not commonly do in ED, or in hospital for that matter, personally, I haven't done it myself for all the APOs that I've looked after, but it's very much an available therapy, but is very common in AV treatment of APO, is GTN. This is usually done through a GTN patch when I have received patients that have been treated by AV. GTN is utilized due to its vasodilatory effects. Vasodilation decreases preload, reduces the strain on cardiac function, and improves oxygenation, but this can have significant impact on BP. Now, I was thinking about it, and I didn't initially have a case study to provide with this lesson / story / episode, whatever you want to call it. But upon finishing my script, I was reminded of a particularly meaningful case that occurred about 4 months ago. Actually, 2 days before my first arrest, which was pretty unfortunate for me at the time. But I'll give you a little bit of the rundown. This patient was in her 90s, living home alone, and pretty much thriving up until that night, the night I looked after her, where she woke up acutely short of breath at about 2 o'clock in the morning. She called AV, and on arrival, they pretty much scooped her up and brought her to ED, where she was brought to me. At that time, she was saturating okay on a few liters of oxygen. She was noticeably short of breath, but nothing life-threatening. This shortness of breath actually eased for a short period of time while I got the ECGs done, put a cannula in, took bloods, and took her for a chest x-ray. Upon reflection though, I can't actually remember whether she had a GTN patch on. My gut says she did, but I can't remember. But the paramedics, I don't think were treating as APO, rather an exacerbation of COPD. So they'd given her puffers and stuff like that. Upon my auscultation, though, I reckon I could hear fine creps to the mid-zones. And I remember vividly that the AV thought they were wheezes, which is why they went down the COPD route rather than the APO route. But so for context, she was right in front of the staff base, so very, very visible, but she wasn't in resus. And in the time I took to show the ED reg in charge the ECG, she had become hypoxic, acutely short of breath, work of breathing went through the roof. I told the doctor that I thought this was APO based on my auscultation and the chest x-ray, which had showed a fluffy, in quotation marks, appearance, for lack of a better term. But in better terms, sort of the lung infiltrates are highlighted due to increased fluids. Sort of like pneumonia, but they're not patchy and they extend from the midzones. Now, she hadn't actually been picked up yet, so he assessed her, he concurred with my findings, and we moved her to resus for BiPAP, which she had on for maybe an hour or two before stepping down to high flow for ongoing pressure support, but not as distressing, uncomfortable, or invasive, despite having the term non-invasive, as BiPAP. Unfortunately, that night, I had 2 respiratory emergencies at the same time, so I did not get to follow through or even hand over care to resus. But luckily for me, the resus team on that night was amazing, and they just took over from me, no questions asked. I came back that next night, not the night of my first arrest, but the night before, to find out, one, she was unfortunately still in ED. At that time, we were severely bed blocked. And actually in the original cubicle that she was brought into the night before. And two, that she had been made goals of care D, care of the dying. Now that night, just 20 hours after she first presented to ED, so for context, she presented at I think 3 a.m. and now we're at 11 p.m. that night. She passed away surrounded by her family. I'm not exactly sure the progression of her CCF, but I would assume it's end stage. That, her age, eventual quality of life, and even her own wishes probably would have affected the decision to move to the care of the dying pathway. The thing that stays with me, though, in this situation is that I got to help her move to a room where she could be with her family more intimately, because the cubicle she was in was very high traffic and probably not the greatest place to spend final moments with a family member. But through this sort of move, I got to sort of hold her hand, and she actually had remembered me from the night before. And I found that moment to be extremely special and touching, especially considering what happened probably 20 minutes later. But anyway, what I want to take away from this story is the use of BiPAP to shift fluid from the alveoli into the bloodstream where the diuretic therapy is excreted. Bada bing, bada boom, no extra fluid. This is until cardiac function worsens and the disease progresses and we end up back at square one, with medications needing to be increased and adjusted and stuff like that. So in the clinical setting, when you see swollen feet, swollen legs, and shortness of breath, maybe sort of picture CCF as a differential. Another diagnostic criteria that I didn't mention in this episode, and I won't go into today, is heart murmurs. Because obviously not everyone, especially nursing staff, we don't routinely listen to heart sounds. That's sort of viewed as more of a medical diagnostic feature because a lot of people just aren't trained to listen to heart sounds. And to be honest, until you hear a really obvious murmur, they're quite hard to discern. Basically, murmurs are another diagnostic indicator of black flow in the heart and therefore CCF. Basically, the whooshing sound of a murmur is the sound of blood flowing backwards through the valves. But anyway, as usual, I've rambled long enough, so I'll wrap it up here. If you have any questions or comments or your own stories you'd like to share, then please leave them in the comments. I'd love to hear other perspectives. So, this wraps up this episode of my show, Chronicles of a Learner RN, or should I say Chronicles of a Learner CCRN. I certainly have learned a lot, and I hope you have too. I have a plethora of cases and learning experiences I'm excited to share with those of you that are willing to listen. If you enjoy what I do, what I say, and what I can bring to the table, then please comment, rate, subscribe to the podcast. It means a lot. Thank you, and see you next time.